This is the video of laparoscopic cholecystectomy in grade 3 acute cholecystitis. And you can see here the left lobe, lot of adhesions, and there is a collection in between the adhesions. The entire upper abdomen is like a moss. So I put a camera in the infra-umbilical, and this scissor is coming from my right hand. It is on the left lumbar region, and the left hand, the bowel grasper is coming from the right iliac fossa almost. So it is on everything has camera on the left lower abdomen, and lot of adhesions, omental adhesions, and so I'm not able to see the entire liver. So I'm releasing the adhesions. This is the omental adhesions from the falciform ligament I'm releasing now. So the in case camera is in this case camera I put a below umbilicus, left lumbar and right lumbar is coming the working instrument. So once I clear all the omental adhesions, identify the liver, then I have to identify the gallbladder. Then only I can able to perform the cholecystectomy. So this is the exposure difficulties also there in this case. So I'm not I'm finding difficult to reach the gallbladder region because of the lot of adhesions, and the patient is treated with antibiotic, and multi-organ failure was there, deranged liver function, and renal function is deranged. So patient treated outside and then is referred here. So I'm separating the omental adhesions, and we stabilize the patient, and then we are taking it for laparoscopic cholecystectomy. So all the omental adhesions is being released. Till I'm not able to see the liver, I'm releasing the omentum from falciform. Thick omentum is advantageous. It's otherwise bowel adhesions will be there. Colon will be adherent here. So I'm releasing that omentum from the intra-abdominal wall. So now I'm entering the right side, just what I'm showing the scissor. So from left side to right side I'm entering now. This patient had a divarication of recti also. You can able to see the linea, widened linea alba, the white color. So all the adhesions is being released. It is not a previously operated, there is no scar in the midline because of the inflammatory adhesions, very densely adherent to the abdominal wall. So omental adhesion released. Now I am going to make another trocar, and that is a left lobe of liver, and this one is I entered with the optic view trocar with the 5 mm on the left side. So now this is the right lateral port I made. So now I could able to see the right lobe of liver. So that is the right lobe of liver. That is the still I'm not and I have to explore the entire right lobe. Then only I can visualize the gallbladder. So I started from the medial side. Now you can see the from falciform ligament I am separating the omentum. So the omentum is separated from the falciform ligament. Identification of anatomy is a little difficult, but if you carefully follow the structure, you can able to find out. So I'm slowly I can able to enter laterally. In difficult cholecystectomy, one of the condition is because of this, the exposure difficulties is there. Gallbladder may be sometimes easier, but because of the previous surgery in the abdominal wall, upper abdomen, the exposure difficulty will be there. But this case, it is no previous surgery, but because of the extensive inflammation, and this patient had a empyema gallbladder because of the acute infection and grade 3 acute cholecystitis. A lot of adhesions is there. So I'm using a suction nozzle. I'm going close to the gallbladder area now. It is a perforated gallbladder and sealed according to the imaging. CT shows perforated GB and then sealed. So I'm expecting collection there. So now I could see the liver surface, inferior surface of right lobe of liver. I'm going from there. So I'm doing very carefully. I can confirm the structure, then only I can separate or I can divide. So I'm slowly using the suction nozzle. It is like a finger. It is my finger in open surgery. I could able to separate the omentum from the liver. So that can be divided. It's a organized tissue. So I'm dividing that one. It's a thickened peritoneum only. So slowly I'm going towards the diaphragm. I'm separating the right lobe of liver from the diaphragm. You can appreciate here. These are all the additions of right lobe and to the diaphragm level. So I'm releasing it. All organized adhesions. So that area will be the gallbladder area. So the dense omental adhesions is there. So falciparum is separated from the liver, and then I told in my previous video, the adhesions of the omentum, you have to take it from the quadrate lobe, that is a medial side. Quadrate lobe, you have to separate the omental adhesions, then only you can reach the gallbladder in a correct plane. So I'm trying for this because of the falciparum is densely adherent to the liver. So now slowly I could separate the omentum. So I could able to identify the gallbladder. That is the gallbladder. So you can see the perforated gallbladder with the omental covering. The fundus of the gallbladder got perforated. The very dense omental covering is there. So now I could able to see the gallbladder. So my instrument from my right lateral bowel grasper, I'm holding the gallbladder. I'm slowly going down, separating the omentum. You can see very simple gallbladder. It is easier, but acute how much difficulties is there because of the grading. Patient is waited for long time or treated. So all those things happen. So I'm slowly separating the omentum. That is, I feel I'm going through the omentum here. So again, I'm going up. I find the plane. So again, that entire omentum is being pushed down. You have to do it very slowly. Otherwise, you go through the omentum, bleeding will be there. So our aim is to separate the omental adhesions from the gallbladder. And it is, you can see, it is a very much distended, thick-walled, perforated gallbladder. Even though it is perforated, it is a very distended and thick-walled gallbladder. And I could see the abscess in the gallbladder wall. You can see the wall is, it's a white color. That means there is an abscess. No, that's why it's called empyema of the gallbladder. The empyema is one of the difficult type compared with the gangrenous type because of the dense adhesions will be there to the surrounding structure. So, I am not able to separate with the suction nozzle, I am using a harmonic scalpel. That may be the perforated site, it is densely adherent. So, here I release the entire momentum from the upper abdomen and then momentum from the falciform ligament. Left lobe liver adhesions and collection I released, and I clear that area. Then I come for a falciform momental adhesions. Then I went laterally. I release all the momentum. Then I could see the liver, right lobe of liver. Then momental adhesions on the gallbladder is released. Now you can see the another perforation. So it is a perforator at multiple level, and my aim is first thing is to release the momental adhesions from the gallbladder. Second thing, my primary aim for acute cholecystitis is to identify the infundibulum, separate the infundibulum posteriorly, lift up the infundibulum from the surrounding structure. See, you can see the pus is coming up from the gallbladder wall. So, that is the empyema of the gallbladder. So, once I find out the infundibulum and then I lift the infundibulum from surrounding structure, then I could do the calyx. I can identify the calyx structures very well. Critical way of safety can be identified. So, that is my aim. Now you can see the entire right lobe, inferior surface of the right lobe I could able to see, and the right lateral side I can able to enter. Only the medial side it is still attached, so I am not able to perform. So, what I did, I just started the structure mobilizing from the falciform ligament. So, this is the antrum, antropyloric region. I am separating from the falciform ligament. You can see all the tissue now very much inflamed, a lot of plaques, adherent. So, it is very difficult case. So, now I am reaching the middle of the falciform midline. So, once I identify this uh, portal area, then I can know that is I can able to go down. So, now this is the dense adhesions on the quadrate lobe of the liver. This might be all the perforated gallbladder, and momentum goes and adherent to the surrounding structure. So, I am releasing the momentum. Now, I could see this, it is a porta is there. So, now I am going. So, I clear that gallbladder content is, I am just aspirating the content. Now, I am going down. I have to identify the infundibulum, then only I can be able to reach the calyx. My aim is not to identify, not to dissect the anterior calyx to identify the cystic duct and artery. My aim is to identify the infundibulum of the gallbladder. See, now you can see the infundibulum is coming out. Once I identify the infundibulum, I dissected anteriorly little bit and then posteriorly, laterally. So, I could able to lift the infundibulum. So, that is the infundibulum. Lift the infundibulum from the surrounding structure. So, I am holding the infundibulum now. And that is the infundibulum of the gallbladder. If it is posteriorly, infundibulum is lifted from the surrounding structure, then what happen now, if I lift means the cystic duct and artery becomes straight, and then the calyx is on the view. So, entire anatomy is being very clear after doing that step. So, I am separating the infundibulum from posterior attachment. Simultaneously posterior and anterior I am doing it now. Now, you can see it is coming out. So, it might be stone, might be there, and so that is the infundibulum. Once its infundibulum is coming out, and you can able to see the duct and artery very well. So, after that, so that is the infundibulum is complete. After complete mobilization, that means all the attachment of infundibulum is released. So, now its identification of the calyx, cystic duct and artery is very easy. Now, you can see the artery is in the view. In my unit, most of my acute gallbladder, even grade 1 to 3 and gangrenous, empyema. So, most of the time I can able to do total cholecystectomy. I could able to find out the cystic duct. You can see a cystic duct is delineated. I am applying a Hemola clip now. So, I could able to identify the cystic duct CBD junction. I can able to put a clip. The type 2 subtotal cholecystectomy is very rare in my unit because of these steps. Separate the momentum, go down close to the GB wall, go down, find out the infundibulum, and then separate the infundibulum from the surrounding structure. You can able to see the cystic duct. Now infundibulocystic junction is being divided. Basically cystic duct is clipped, doubly clipped. I am not leaving any tissue, and so this is a widened infundibulocystic junction. So I am just clipping that area and dividing it. So once I divide this, I can go up, go medially. Then I can able to see the cystic artery. Once I divide the cystic artery, then only separation of gallbladder. So now I am going up, going to the medial side. So that if you see the node, you can be happy, because node is usually present above the level of cystic artery. So if you see the node, just below the node, cystic artery will be there. So now this case also same, below the node I could see the cystic artery. I am separating the cystic artery. See, that is the cystic artery. I am clipping the cystic artery. So by without mobilizing the infundibulum, if I dissect the anterior calyx, definitely now I will open the gallbladder. The anatomy is not at all clear, so it is very difficult. So once the infundibulum is separated, now you can see the calyx. No, it will lifted. I can able to lift the calyx because the post attachment is separated. So a cystic artery and duct become straight. So I could able to find out easily, and then I am clipping and divided it. So now I am started separating the gallbladder. So the type 2 subtotal is avoided here, even though if it is very difficult, I could find out the cystic artery and duct I clip. So here I am trying to separate the gallbladder from the liver bed, and most of the time now it will be very densely adherent post wall. So I leave the posterior serosal wall of the gallbladder to the liver bed. I am taking the entire anterior wall and the entire mucosa of the gallbladder. So it is called type 1 modification. So I am not leaving any gallbladder mucosa, only the posterior serosal wall is being left behind to the liver bed. So only the type 1 cholecystectomy is I'm doing here. And if I try to remove the post wall of the gallbladder serous wall, then lot of liver surface will be injured. So that that I left behind the posterior serosal wall. You can see even the between the mucosa and serosa also lot of collection of pus. Now you can see the mucosa, it is like a white color. It's almost gangrenous, and pus is there between the mucosa and the serosa. So now you can see the pus is coming down. So it is a empyema gallbladder. So basically it's a complete cholecystectomy is being done. Cystic duct and artery is clipped. So you have to follow all the rules and place the port in a normal area. Clinically under anesthesia you can palpate. If you feel like a mouse like lesion, and then you can put the in this case I put a VC port, then I enter with the other port, then I release the left lobe liver adhesions first, then omental adhesions, then I could see the right lobe, then I separate the right lobe from the diaphragm, then I could find out the omental adhesions from the separate the omental adhesion from the falciform ligament, then from the gallbladder, then I identify the gallbladder, then I identify the infundibulum, I separate the infundibulum, then I can able to identify the cystic duct and artery, then I clipped and divided. So these are all the steps to be followed. So this you can see, dense adhesions of the inflammatory plugmon is become a like a fibrous structure because of that long time waiting. So I am separating the adhesions between the liver and the diaphragm, right lobe of liver and the diaphragm. You can see the fluid is coming. These are all the toxic fluid. You can take out all the adhesions. You have to give a nice wash with the saline, so that the patient recovery will be faster. See, now these are all things to be released. Otherwise, these collections will producing subdiaphragmatic collections. Patient might get pleural effusion and breathing difficulties, and delayed recovery will be there. So all these things will be avoided by doing this step. And after this, I have to wash very thoroughly with the saline, around 3-4 liter or 5 liters of saline, so that entire no, debris will be taken out, bacterial load will be reduced. So now entire thing is done. So I have to place the bag. So plastic bag, sterile plastic bag. So I'm placing the gallbladder into that. There is no space. Normally, previous case, if you see between the diaphragm and the liver, a lot of space will be there. I place the gallbladder into the endo bag. Then I divide it into 3-4 pieces. Then I'll take it out. Otherwise, no, it will not come through the 10 millimeter port. So here there is no space. So I'm dividing the gallbladder wall. You can see the very dilated, thick walled gallbladder. So I'm dividing in a multiple piece, around 4-5 pieces, and then I placed into the endo bag. I'll take it through the epigastric port. So since I placed into the endo bag, I'm taking it out. So epigastric port will not get infected. Now you can see this, entire sloughed out, gangrenous and empyema of the gallbladder. I asked the sister to hold the bag on the other side. I'm holding it on this side. So I'm placing it into the endo bag. So that made the infundibulum stone. See, that is a stone in the infundibulum. So this is the reason, for cystic duct obstruction, and then initially lymphatic flow, then venous flow, then artery flow will be obstructed. So its gallbladder become a distended edematous, and then become a gangrenous, then empyema. So it is all everything is placed in the endo bag. So I put with the Kelly clamp. I am taking out the bag. So I take out all the content and then I clear with the betadine solution. The port side will be clean. Then finally we have to give nice wash, thoroughly all the area to be washed. And I keep a drain. This case definitely, even though it's duct and artery is clipped, drain to be must. And lot of wash I give that I edited. So entire subdiaphragmatic, subhepatic space and left diaphragmatic space, everything is washed. And then I keep a drain. This is for 1 or 2 days I'll keep, and then I'll patient is recovered well. Then I'll remove the drain and I'll send home. Thank you so much.